Well, good afternoon. It's really a distinct pleasure to be back in Singapore. A few of you in the audience will know a little bit of my heart has been in Singapore for more years than I really care to remember. And coming back is always an absolute huge pleasure for me. What I thought I'd try and do this afternoon is really talk, use my own career to really give you my thoughts about advancing women in healthcare and how in a way we have advanced very much, certainly women in medicine, but what are the real challenges that still face us? And so part of this, I'll talk to you a bit about my own journey. I was born in the middle of England in a village called Barwell in Leicestershire, very much an industrial village. Not a pretty village, not the idea of your beautiful English village. My university was Bristol, where I did my first degree in the humanities in history. I then did some training as a social worker, medical social worker, before I eventually landed up starting my degree in medicine. And then I had a long career in medicine, in clinical medicine, research medicine. And it's only more recently that I've taken on quite a different role in Cambridge as head of one of the female colleges in Cambridge. But it really was my past of trying to help women in medicine, women get to the top of medicine, that made me think it would be really challenging and very interesting to run an all-women's college today, because of course there are challenges in running an all-women's institution. We have 3 women's colleges in Cambridge. Oxford now has none. So I was born in this little village. It made shoes. I went to a grammar school in Market Bosworth. Market Bosworth was where the Battle of Bosworth was fought, where Richard III lost his crown and his head, but we recently buried him in Leicester Cathedral. But at school, I wanted you to know I was fat, working class, poor at games, not as good as some of my city student colleagues, and I definitely lacked self-confidence. And it's just how do you deal with these things as a woman, irrespective of whether you're going to go into healthcare. I was so fat that in my gym slip, we wore gym slips in those days. For those of you who are much too young to know what a gym slip is, it had pleats at the front, pleats at the back, and you tied your sort of belt around it. Well, I was so fat, my pleats didn't pleat. And therefore I was very, very poor at games. I didn't play games. And the reason I took up running much later in my life, one was to have some peace, but secondly, nobody could watch me doing it. I could go out in the early morning in my tracksuit. But my school helped me build confidence, and I think this theme of confidence building, whether it's women in healthcare or anywhere else, is crucially important. And I must have started to get some things right, because in my last year at school, I became head girl. Now, when I went into the sixth form to do my A-level exams, I didn't know whether to do arts and do English and history and geography, which I ultimately did, or whether to do biology and physics and chemistry. But I had a crush on the history master. It was not much more difficult than that. He disappointed me terribly by marrying the domestic science mistress. But anyway, I was destined at that point to do a degree in history. And I went to Bristol University, and you can see the tower of Bristol University there. And quite frankly, I hated it. I realized very quickly that I thought history was about people. I believe people change things, and I thought I wanted to understand and study the great people in history who had brought about change. But It was taught very boringly, and I seemed to learn a lot about constitutions and battles, not much about people. But I was surrounded in my hall of residence by medics. And I suddenly realized that medicine was about people, and how silly of me not to have done science at school. So I wasted a lot of time in my first degree. I became head of my hall of residence, president of the Bristol Student Union. In fact, I did everything but work. And I'm not going to waste time telling you how difficult it was to switch to medicine, but it was difficult to switch to medicine, and I did not become a medical student until the age of 25, almost 26, by the time I switched, which, you know, when most people in the United Kingdom would be going to medical school at the age of 18. But I think the first lesson along this journey that I wanted to share with you all, whether you're men or women, is you don't have to get it right first time. As you can see, I got it rather abysmally wrong. I didn't get it right, but I did finish my first degree because no one in my family had ever been to university, so I thought I really had to at least get a degree. And once I was allowed to switch, although the first year when I had to do physics, chemistry, and biology, I found very difficult. Once I was actually into medicine itself as a degree, I really realized I was where I wanted to be. I mean, I have loved medicine as a career and can't think of a better career, but it was very good to have had a background in the humanities and in social work, and I valued that as I've gone through my life. I must say it was a patient that determined my choice of specialty. I didn't particularly want to do rheumatology. I am a rheumatologist, but my professor of medicine told me I was 8 years older than everybody else. I should find a specialty as a woman that would allow me to go to the top of the specialty quickly, and therefore I shouldn't look at specialties in the United Kingdom which were already full, and we had a cap on the number of consultants that we would be appointing. So I decided to be a rheumatologist, and it was a young woman of 26 who came in when I was very recent. I just finished training. I was on the night shift. I admitted this woman with a disease called scleroderma. Some of you in the audience, I hope, know what that disease is. Many of you will not. It's a rare disease. 26 with kidney disease, acute kidney failure. I asked my professor how would we look after her. I'd never seen a patient with this condition. And he said, we will not be able to treat her. She'll be dead within 3 weeks. Indeed, she was. And I decided very early in my career that if I ever had the opportunity, I wanted to become a specialist in that disease. And we didn't have a centre for it in the United Kingdom. And I wanted to set up that centre. It was really quite early that my whole career, in one way, I began to see what I wanted to do. So I did my full rheumatology training, and then I specialised in a rare disease. And there were very few people in the world who specialised at that time. And the really father of this disease was a great man called Jerry Rodnan in Pittsburgh. And Jerry said of this disease, may the struggle continue until this most obstinate of diseases is made to give up its secrets. And when I started doing my research, it had many more secrets than it has today. It still has a huge number. But it was a great career because I was able to establish myself with a clinical centre and a basic research centre in an area where very few people were interested. And therefore you got to know your international colleagues really very, very well. And it was very good for self-confidence, and it was very good for creating an international presence. And at that time, there were very, very few women really on that trajectory. Of course, many of you will know that Paul Klee, the very famous artist, died very early in his 40s of scleroderma. And of course, it's a disease that turns you to leather. and your hands become claw-like. You can see that in the bottom picture there. And Paul Klee, as he went through his life with this disease, his last painting was that one there, 1940, and this big, he had to use big paints, brush streaks there. He couldn't any longer do it in a fine way. And that whiteness is the whiteness of the Raynaud's of this disease. It, for me, is a very powerful, evocative painting of scleroderma. But I was at that time very much a woman in a man's world, in a very unusual disease. And some of the things I had learnt at school were important to me. And of course, what is always rewarding, I think, is to have your patience, and I must say I miss patience. And it was always great because anything you did for patients with this disease was an improvement. You couldn't really be making it worse. And it really, over the years that I was involved, it gradually did get better. We still don't know what causes it, but we can certainly, for some patients, not all, we can slow it down. So I think that the first sort of set of lessons I learned as a woman moving into medicine, leaders are not born. You could say I was born in rather poor circumstances. No one in my family had ever gone to grammar school, let alone to university. So I don't believe leaders are born. People don't come out of the womb carrying the banner leader. I think one is capable of developing these skills. I don't think leadership is the act of a lone genius. We often think it is always the person at the top of the organisation, but leadership can be at many, many levels as you go down an organisation. You can be leading a small group. You don't have to be leading the whole lot. Some leaders aren't terribly charismatic extroverts. Some are, but you don't have to be that to motivate and inspire others to follow your vision. And some forms of leadership does not require formal authority, and you can see that all the time in small ways in which people take on leadership roles for which they have not necessarily been given formal authority. And I don't think, personally, that all leaders have a common set of personality traits. Again, just thinking about leadership in healthcare, many of these quotes on this slide were taken either from our medical schools council at home or from University College London in an inquiry by one of the select committees in our parliament. And here you can see saying that students can be biased in their perceptions of leadership, with medical school students, female and male, saying that men generally make better leaders. Well, why should that be? But that is a perception that some people still have, and that women who display leadership qualities may be judged negatively as presenting stereotypically masculine traits. I often think women's leadership is different from male leadership. It's not better, it's not worse. It is and can be different. And it's so wrong to think if women don't display those leadership qualities that we associate often with men, that they're unsuitable for a leadership role. Now, these quotes are actually very recent. They were from a report of this particular select committee only 2 years ago. Leadership in healthcare, I think, is really very interesting if you go into it as a doctor, which I did. I never practiced as a medical social worker, although I obtained the qualification. And of course, I thought that leadership was all about clinical leadership for my specialty. I thought about it was leadership of my laboratory and the research we were doing. So I was deeply involved in clinical and research leadership. But I sort of, in 1999, things changed because the chief executive of my hospital, which was one of the London teaching hospitals, Royal Free, which is one of its pictures is there, said to me, well, Carol, we'd like you to become the medical director. I said what most women often say when offered or considered for another job. I said, well, I don't know anything about management. No, I think there must be lots of other people, I said, who could do this job much better than I. Talk about talking yourself out of a job. I think women often talk themselves out of jobs, but they didn't let me talk myself out of that job, and I did become the medical director of the Royal Free. Of course, some of my medical colleagues, particularly my research colleagues, thought I was joining the dark side, the management side. What was I doing as a senior physician doing this? But it was an eye-opener to me, because I had to stop being what I'm going to describe now as selfish. I practiced in one way selfish medicine. I practiced the medicine of my own specialty, of my own particular research interest. I was passionately interested in it, but I didn't think about my hospital as a whole, its financial affairs, the fact that it had to serve a whole population, and I had to start and recognize and accept that link between improvement and change. I had to understand about managing threats and disturbances and disruptions. I had to be prepared to take on some of my medical colleagues in a way that I'd never been used to before. And so I really did learn quite a different set of skills about governance, about management versus leadership, as I've just said, about doing the difficult thing. And I had to be able to make things happen. And I had my first real experience was sitting on serious boards where controlling vast amounts of resource. That was very good training for many of the other things I've done subsequently. And I had to really start to think about population health. I became much more interested in public health, rather than the individual person just in front of me. And of course that is a tension. And it's a tension when there are only limited resources around. But this was a real growth period for me. By then I was, if you like, at a stage in my career where no family commitment would have stopped me becoming a medical director as a woman. But one of the things I was very conscious of at that time was that all our meetings happened at very inconvenient times for women. We used to meet at 8 in the morning. What happened if you wanted to take your children to school? We often had our board meetings at 5 to 7 in the evening. And the whole of the arrangement of meetings was not really friendly to anyone who might have other commitments, and particularly to women who were trying to rise up through the profession. And when I did my first report for the Royal College of Physicians on women in medicine, I remember interviewing women who said they couldn't even consider putting themselves forward as a medical director until their children had got to a certain age, because the whole arrangement in the hospital was not going to favour this at all. My life changed yet more when I ended up being very involved in the Royal College of Physicians. Royal College of Physicians is the oldest professional organisation in England. We're nearly 500 years old, as you can see, founded by Henry VIII in 1518. And so the oldest and really the most prestigious of our medical royal colleges. When I became president in 2002, I was the second woman to ever get that post. Of course, we've now just, thank goodness, elected another woman, but it's quite difficult, even now, for women to get elected to this particular position. And I never thought to put myself forward for it, which is something that women are so bad at doing. It was people when I first got involved in the college, somebody said you really ought to sit on council. So I stood for that and I got elected, and then someone said you'd make a really great clinical vice president. So I stood for that, and then people said, well, you ought to stand for president. But I realized it was people asking me, without me having enough confidence, to think, well, I could do this job. I mean, lots of men have done it. And at that time, the then treasurer of the college told me, as I was standing, he wasn't going to vote for me. We'd had one woman, and we didn't need another woman for 50 years. And anyway, as he explained to me, there were many, many good men standing, and I wouldn't get elected. He found it very difficult to congratulate me on the night of the election, but he did, and that was fine. But now I was in quite a different position, which many women might have found themselves in at that stage, the early 2000s, that I was now leading a professional body that had many, many more men than women. And I had to have been elected by men because we didn't have enough women fellows for the women to have elected a woman. We just didn't have enough at that stage. It's different now. And in our last election, the women's vote was actually very powerful. You could trace it through the single transferable vote. So I now had to understand that I was leading an organisation which was primarily male, and I had to be able to be a good leader for both the men and the women in this organisation. And I had to understand what I would describe as consensual leadership. I had some powers, but certainly if the fellowship had turned against me, it would have been immensely difficult. We had a large fellowship and an even larger membership. So we were a membership and fellowship body. But the tension now was not population health versus individual patient health, but the tension was, could I lead the profession and also negotiate with Whitehall, with government? And that was a huge transition for me, because now I could get access to the Secretary of State quite easily. I could get access to the senior civil servants, but I was in that position that I was representing the physicians, and I was now having to meet with people I had no idea how to deal with. How did you negotiate your way through the politics to start with, and then through all the arms of government? And that was an absolutely huge learning curve. And probably the biggest thing I had to do was to build trust. Because if they didn't trust me, then I wasn't really going to be enabled to be accepted into the Whitehall scene and be able to go to the Department of Health easily and be welcomed. After 4 years, it's a 4-year term as president of the college, I was elected to chair all the medical royal colleges. So we have 21 of them, and they've all got A-type personalities. And of course, the worst of all are the surgeons, absolutely, without any doubt. And they all thought they were better than each other. And I was their first woman chair. And of course, as chair, you had no executive power. Now I had to get 21 medical royal colleges to talk together, because that's what the government expected me to do, and to be able to take some consensual views to government. They didn't want to ask 21 bodies. And then I found my leadership had to be quite different, because then it was, I spent hours persuading, cajoling, aligning forces. You needed to have great patience, and you had to go back many, many times to each of these organizations. And I learnt patience. I learnt that I couldn't be in a big rush, and that there would be times when I would have to say to the government, okay, I've got 20 colleges on this side, but there's one out here, and it really will never come over here, and that's where we are. So there were times when it was extremely difficult, And I would say of most of the jobs I've done, this is the one from which I bear the most scars. It was a really very, very difficult negotiation. I moved on into health policy, and this has been one of the really great joys of a different kind of career in medicine. And I think women can go into any of these branches. I became the chair of the Nuffield Trust, which is really a think tank. It's an independent source of evidence-based research and policy analysis for improving healthcare in the UK, much sought after by governments both from England, Scotland and Wales. And we do typical reports, like is our general practice in crisis, NHS hospitals under pressure, highly independent reports. And that gave me the ability to get far more engaged at a very different level of being in health policy itself. But that period of my life from when I left my own hospital, for a time I tried to keep clinical practice going. I did a day a week while I was president of the Royal College of Physicians, but I began to realise that it was not going to be, I couldn't carry on, so I did have to give up clinical medicine. But all the time I was learning to take greater risks. It was a huge change, and in a way a risk to me to give up the hospital, the place I knew, the place I'd grown up in. And I think I was interested in reading this book, a book that came out of America, although one of the authors is a Brit, an Oxford graduate, that many women, many girls learn to avoid taking risks and making mistakes. And I realized what I was doing was increasingly taking risks, and I want to encourage you in healthcare as women to think you can move across the different bits of healthcare. And I do think being able to start to take risks is very good for confidence building. And I think, again, men and boys, they tend to absorb what often one might describe as scolding, or they take this better than we do. I think almost they learn to take failure more in their stride. And I've just put there one of the quotes from this Kay and Shipman book, The Confidence Code. Complicating matters, girls and boys get different patterns of feedback. Boys' mistakes are attributed to lack of effort, while girls come to see mistakes as reflecting their deeper qualities. I think that's worth reflecting on. And this is again taken from this book. Men don't let their doubts stop them as often as women do. I nearly didn't become president of the Royal College of Physicians. I had loads of doubts, but it was a great opening into Whitehall and to government. And we sometimes hold ourselves back not taking risks, and it's often the choice not to try. And I always say to people, and particularly to the women that I've mentored, if you don't apply for something, you can certainly not get it. Of course, you know, if you apply and you don't get it, you may have to cope with failure. But if you don't apply, there's for one thing is absolutely certain: you certainly can't get that job. I think in the UK, I thought you might like some figures. 77% of our total workforce in the NHS, which is 1.6 million, is the workforce of the NHS, is female. And 41% of our chief executives are women. 81% of our non-medical staff are female. And 7% of female staff are doctors or dentists. And 2/3 of our female staff work full-time. And then we have about 10% of female staff that are born outside of the United Kingdom. I tried to get some up-to-date figures on our women in management in the NHS. And these were the very latest. I got them, in fact, sent out while I was in Australia. So I just put this slide in, but you can see there that of all our administrative managers, we have a high percentage of women. We have a high percentage in senior management, but the areas where women tend not to go into, become no surprise, are estates, property and hotels, and into our ambulance service support. So there are certain areas which women choose not to go into in the NHS. I'm going to give you a few slides on what happens to women in medicine. I'm sorry I don't know so much about nurses or about physiotherapists, but I have, for the Royal College of Physicians, been very instrumental in 2 reports on women in medicine. And I think in medicine we have been very fortunate, and meritocracy has certainly been achieved in our medical schools. There is not a single report in the United Kingdom that provides independent evidence of systematic bias or barriers against women's advancement in the profession. People perceive there are barriers, but you cannot go and find any report. And women in their specialty choices do very well. And progress to the consultant stage, I suppose, so in the American system that would be the attending, I think, stage, has now become absolutely the norm for women who pursue a full-time career. Not so true for women in part-time medicine, and compared to other science subjects, to mathematics, to engineering, etc., I think in medicine we progressed very well. We stay in medicine, so retention within the medical profession remains remarkably high, and that of course I think is true of nursing. We've got a large and growing range of specialties and subspecialties to choose from. I think at my last count we have about 68 specialties now in British medicine. We do have a common pay scale, which cannot be said of women often in other professions such as business and perhaps even in the law. And therefore UK medicine offers a very good career for women in comparison with other leading professions. But there's some very interesting trends, and I don't think these will surprise you. When we did our second report on women in medicine, we looked at whether women went into specialties that were more people-orientated, more plannable, or did we want the more unpredictable or the more technologically orientated. And you can see there that, in fact, we were quite keen on the predictable and the plannable, which were people-orientated. So childcare, child health, general practice, family medicine, psychiatry, and public health. Of the unpredictable but people-orientated, obstetrics and gynecology. But when you come down to the more unpredictable and the more technically orientated, women were not actually going to them in such a big amount, but they included anaesthetics and the surgical groups. And I think we're very, very lucky in medicine, because whichever of those specialties women chose, they had the choice to get up to the consultant level. I don't believe we had barriers, although not many women still in British surgery do go up to the consultant level. But if you look at the long-term career model for doctors, then it doesn't have a funnel shape. It's a nice round tube, and as long as we're doing well, we can go all the way up to a consultant status. But you take a partnership model, say you worked for McKinsey's or Deloitte's or PwC, there will be an attrition from the bottom of the associate training all the way up to partner status. And you see this very much in some professional firms. The advancement rate, it goes off with time. Intake, large; advancement to partnership, small. So I think we have to remind ourselves that in many ways, certainly within medicine, women have done well. But there is something I want to talk about which I think would be true of other specialties, not just healthcare. And we see it in our women managers in healthcare at home, is how do you get women to go the last step? Of the 200 top jobs in British medicine, still very few of them are occupied by women. So when you start to go from the consultant level up now to chairman of the GMC, president of the BMA, presidents of the medical royal colleges, etc., chief medical officer, thank goodness a woman at the moment. But how do we get women to go onto that leadership dimension, which now requires something quite different? And this is where we certainly have got a challenge. And I personally think, and it's not easy, that this then requires that you invest time over and above what it requires to get to be a consultant, which of course is a very good level to get to. Because in healthcare, whether you're a nurse, whether you're a doctor, whether you're a physio, whether you're a manager, I believe there is a stewardship contribution. And I feel it very strongly as a doctor that in all the jobs I've done for British medicine, I just was on a journey. I was part of the pattern, but I had a stewardship role to make sure I didn't leave that job worse than I found it, and preferably better than I found it. And that was going to, I'm afraid, take time and energy, and I wasn't going to be able to have everything. Something else in my life might have to take second place. There would be trade-offs, and I am not one of the people who believes you can have everything. I believe for many things in life, if it's demanding, if it requires you to become a real leader, then I believe if you're being honest, there will be trade-offs. But we all make trade-offs in life anyway, and it will mean competition. And so you can't shy away from that. So it requires this high degree of single-mindedness. In our big hospitals at home, in our academic health science centres, still we are short of women actually at the top, being the chief executives of those organisations. And so I think women choosing that route need encouragement and support. And this is where I think not just mentoring. Mentoring's useful, but I think what women also need are sponsors. Sponsors are different from mentors, and they're going to enable you to meet the right people, to get into the right slots at the right time, to be there for you, to sponsor you. And I do think that men often have better sponsors than women. Medicine in the UK at the moment, I think, is in a good place. Our permanent secretary is a woman. Our chief medical officer is a woman. We have one fantastic CEO of one of our major hospitals, Julia Moore, at Birmingham NHS Trust. We have 1, 2, 3, 4, and I should have put another fifth. We have 5 women presidents of medical royal colleges. So, but you have to keep feeding that line. You can't rest and think that the battle is won. You must keep making sure that women have that opportunity. So I think the present agenda in the UK certainly is that in trying to ensure that women can do what they would want to do and get to the places they would want to do in healthcare, you've got to really think about quite a lot of things, and the changing workforce preferences are important, potential funding consequences, the development of that consultant role. People used to say to me, well, why would you want them to get more than a consultant role? A consultant level is a very high level. And I'd say, but, you know, it's fine, but it's not the top. And why shouldn't women be able to go to the top? So, of course, the consultant role is good. I think we need to understand trade-offs, and we need to give women as much as we can opportunities for working flexibly. And that, of course, in healthcare is difficult. I mean, there are jobs where flexibility is not so easy because of patient need, and I'm very aware of that. So there are different kinds of success. I don't want you to think that I think going right to the top is the only form of success. It most certainly isn't, but the opportunity should be there. So I think all positions on that line that I've drawn are equally valid. Part-time working may give you great satisfaction, and it may be a great success. Full-time working equally, or full-time plus these extras that I've talked about. But I think with each of those commitments, you will see the time commitment is really pretty important. And so I think going forward, there's a lot of work for us to do at home in improving the quality of management practice so that women do have the opportunities to get very good advice throughout their careers, and this is certainly not just true for doctors, that performance is soundly and effectively evaluated, and that we give proper and good feedback at every level. I'll just, in the last few minutes, I may come back to when I really moved away from what many of you will consider mainstream medicine, because until that point, I had still been very much, even in all the work I did at the college, my interactions with government, very much centred on health care alone and health policy. But in 2006, I suppose you could almost call it a light bulb moment, I was asked by the government whether I would apply for becoming their first national director for health and work. And I said, well, I'm not an occupational health physician. I don't know much about the workplace, and I know virtually nothing about business. This was all about how could we improve the health and well-being of the working age population at home, how could we reduce sickness absence from the workplace, how could we ensure that people were able to work to an older age. And it meant that I was not going to have to just work with the Department of Health, but with our Department of Work and Pensions, our Department of Business, Innovation and Skills, the Cabinet Office and the Prime Minister's Office. This, of course, made me learn things in a very different environment. I now had to get used to trade unions, working with industry and business and the third sector, and advise government. And the penny dropped that I had always thought health was about what diseases we got and whether we as doctors could treat them well. But of course the determinants of our health, the real determinants of our health, are on this slide. And one of the major determinants of health is whether you have work or you are unemployed. And that growth in my understanding of this agenda has been probably the most enormous step I ever took, either intellectually or emotionally, really, because it led me into a very different world. It led me into the world of understanding what work really is. It made me go back and think, well, why did doctors not understand this? Well, in fact, we did, but we've ignored it, because Galen said, employment is nature's physician, and it's essential to human happiness. For us to be in work, preferably good work, provides us with psychosocial needs, it provides us with status, it provides us with money, it gives us self-confidence. And long-term unemployment, this picture is just taken from the Great Depression many, many years ago, and that's taken from an article from Glasgow in Scotland. We know that if you are out of work, it's a greater risk than most dangerous jobs. It affects children who grow up in workless families. And when I did my first report for government on the health of the working age population in the United Kingdom, I told the government it costs them over £100 billion a year, which is the cost of running our health service. Of course, they're quite small costs if you look at an American budget, but they're still very big costs to our our services at home. And one of the joys of doing this type of work is that I've been able to do 2 reports for government. I've put them there. I've been able to look at the journey that people take when they're in work, when they leave work and go into our welfare system or our benefit system, which is a place not to be. And the Prime Minister's just asked me whether, if we do have a Conservative-led government, if I will do a new report on some chronic lifestyle conditions and welfare provision. So it's enabled me to move long and far beyond diseases. And advising government, and again, I'm really pleased that I see so many senior women in the civil service, is being able now to really give an honest and independent opinion, that they should never know what my political views are, crucially important, that I build trust and respect, and that I can become, and hope I am, an ambassador for good work, keeping people at work and enabling them within the workplace to get promotion of their health and well-being. And in these 2 reports, I did try to exert leadership. I tried very hard to make recommendations to government which they could accept and which they would put into practice. And from both of my reports, the government has indeed rolled out a programme of work which did require some changes in the legislation. And then very finally, you might wonder, well, how on earth did I end up at Newnham, an all-women's college? And I think, as I said at the beginning, I really, when approached, had never thought of being a head of house at Cambridge. It had never been in my head at all. But when I thought about it, I'd spent much of my life trying to get women to the top of medicine and healthcare. And so what an opportunity to be able to lead a college where I would want women to develop their full potential and their self-confidence, and to leave us with aspiration. And I want them to leave us with an ambition for leadership. So I'm in now a different phase of my life, where I still do the work for government, but I have this wonderful collection of women to, I hope, inspire and provide some leadership too. So I hope you can see from what I've said this lunchtime that there are themes emerging, whether you're in healthcare or anywhere else. But if you're a woman, that theme of self-confidence, of aspiring, of risk-taking. I always talk about really being able to brush yourself down after you've failed. It's always horrid. I wouldn't like to tell you how many jobs I've applied for, which I didn't get. People always think that you never had failure. Well, of course, one has had failure, and you just have to get up the next morning and brush yourself down. I hope I've made it clear. I think mentors and sponsors are hugely important, as are networks that we build up. And I think for a woman, it's always easier to be really engaged in your job if your own personal values are aligned to the organisational values. And that, for me, was much easier in medicine. So I think we need to have an understanding about some of the things that still hold women back, a wait until they meet all the criteria for promotion. Men are much more speculative in their applications. Women often perceive that aggressive political skills that they think are required at the top of a ladder may not suit them and may not want to be in that place. It doesn't have to be that style of leadership. And we often aim for perfection. Women often aim for perfection. And if we don't answer all the questions, then we don't often submit a report. And of course, you could wait forever to be absolutely perfect. And we fixate, I think, on our performance. And so in a way, this tendency is an enemy to us. And I like this quote, and it's what I've never wanted to be. She was a what-if person, and because of that, she never really happened. I don't think any of us want to be a what-if person. And I like this quote that if all you think you can see is a dug-out canoe, and that's all that's possible, a primitive canoe, and if that's all that's real for you, or that could be real, then you will never see the ship, and you will never feel the wind blow in its sails. And I think that's what most of us want, whether we're men or women. We want to be able to see something bigger, and we want indeed to be part of it. So I think the future's got many names. I think we have to be bold and take the opportunity and take the risk. So thank you very much for listening to me.